So your camera is not visible. Okay. Hello everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own doctor, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. As many of you know, October is observed globally as Breast Cancer Awareness Month. This tradition began in the early 1990s with the Pink Ribbon movement aiming to shine a light on breast cancer, a disease that affects millions of women globally. This month is dedicated to increasing awareness about early detection, supporting those fighting the disease, remembering those we've lost, and celebrating the courage of survivors. Breast cancer remains the most common cancer among women, but the good news is that with advances in screening, diagnosis, and treatment, survival rates are rapidly and dramatically improving. So, as a bottom line, like we always say, awareness truly saves lives. Joining us for today's session on screening to survival, understanding the breast cancer journey is Dr. Krishnamani, one of the most respected voices in the field of oncology. For over a decade, he has been a key pillar at AY hospitals here in Hyderabad, where he specializes in the treatment of solid tumors as well as hematological malignancies. He has combined deep clinical expertise with a truly global perspective on cancer care. His contributions extend beyond the hospital walls, shaping the cancer care policies, advancing treatment protocols, and driving impactful research. Above all, what patients and families value most is his compassionate and empathetic approach, which has made him not just a doctor but a trusted partner in their cancer journey. Hello and welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And as you rightly said, this is the Breast Cancer Awareness Month. So, our focus today is going to be on breast cancer, and it's a huge topic. But at least what we can try to educate our patients and their caregivers, we will try to do that in the limited period.
So, since, like you rightly said, breast cancer is a huge topic, and there are a lot of advancements in the treatment which have happened. So, we will start with the symptoms, go a little bit into diagnostics, and then concentrate more on the treatment part for our patients to understand better. So, sir, let's start at the very beginning. Like, what are the most common warning signs of breast cancer that women usually should never ignore?
Breast cancer generally presents with a lump in the breast or a lump in the armpit, sometimes with bleeding from the nipple or inversion of the nipple. Okay, if you leave it like that, it will grow. It may reach up to the skin. It may form an ulcer or a wound. It may start discharging. So if women leave a lump unnoticed, and if it is a cancerous lump, and if it keeps growing, the skin breaks off due to the pressure and it becomes a wound, like any other wound. If it spreads to your brain, you can develop severe headache, double vision. Everything seems double. You may have weakness of one side of the body or paralysis, or you may have seizures. Seizures is fits. If it spreads to the lung, you may have cough, you may have breathing difficulty. It may also form water around your lungs called pleural effusion, which needs to be removed. If it spreads to the liver, you patients may develop jaundice or pain on the right side of the abdomen. And if it spreads to the bone, they may have severe bone pains or fractures. So, symptoms are local or systemic. Local is a breast lump, which is the commonest, or an armpit lump, or bleeding from nipple or inversion of nipple. Beyond this, if it goes to other organs, these are the symptoms. And in advanced stages, apart from those symptoms, weight loss, loss of appetite.
So, do the patients come with definite physical symptoms and signs, or are there patients who come to you with subtle signs also, like maybe an accidental finding in some of the blood reports or something along those lines?
Blood reports will not reveal breast cancer. So many a times patient, so how do the patients present? A lady may just come to our clinic and she may say, I just noticed a lump in the breast for the last 2 3 days or 1 week. Another lady may come, she has no lump, she's got a mammogram done, And that mammogram says there is something there. That is called a screen detected breast cancer. That is screening. Your mammogram is detecting the breast cancer even before you developed a lump. The other person is somebody who comes with a lump. Now we have a patient who came 10 days back. 1 year she's been having a lump. She's ignored. It is broken through the skin, ulcerated, bleeding, and she comes with water around the lungs, breathing difficulty. So that is another patient who comes to you in an advanced stage. Okay. So generally, patients can either come with a breast lump or they can come with a screen detected lump on a mammogram or an ultrasound, or they can come with advanced disease.
Are the symptoms different in younger women who present with breast cancer versus the older women?
Younger women are generally said to have an aggressive type of breast cancer. Not everybody. Okay. So, but younger women are, the disease in younger women is usually aggressive, especially if it is triple negative breast cancer. Number one. But also the flip side is younger women are more aware. So today we had a young lady. She came with lumps in the breast on both the sides. She's been having these lumps since 2021. She's had ultrasound in 23. She's had ultrasound now in 25. Both those ultrasounds are normal. The disease has not at all increased. She had an FNAC once, a needle test, which said it is not breast cancer. It is called fibroadenoma, which is not breast cancer. So she's super aware. Any small thing, she wants to be careful that she doesn't have breast cancer, and she actually came for surgery of the breast. So on the flip side, younger women, more educated, those who are urban, those who live in the cities, are they get screened regularly, and they are more they seek medical attention early.
So, can you walk us through the typical diagnostic approach for these patients?
So the diagnostic approach is like how we discuss on cancer reach, as I always tell you, our teacher taught us. I will first do a test to establish a diagnosis. How do you establish a diagnosis? When a patient, first of all, when a patient comes with a breast lump, you will ask them all the symptoms. You have a lump. How big is it? Is it growing in size? Is it painful? Painful lump may not be breast cancer. Sometimes lactating mothers can have mastitis, that is infection or inflammation in the breast. You may think it's a breast, so it is painful. Okay. So sometimes skin infection over the breast can be painful. So how long do you have a lump? How long do you have? Is it growing in size? If it is not growing in size, may not be breast cancer. If it is growing rapidly, it may be breast cancer. Sometimes it may bleed inside the cancer, inside the lump. That's why it will grow quickly in size. Okay. So you're going to ask about whether you have a lump, its growth trajectory, etc. The other things which we are going to ask very commonly is a lump in the armpit, bleeding, and etc., and other physical symptoms. Family history of breast cancer is extremely important. You should ask any first, second degree patients have breast cancer. Anybody had ovarian cancer? Any men with breast cancer? How many have you been pregnant? Have you had kids? Because risk increases if you are nulliparous. That is, if you don't have kids, or if you have never been pregnant, the risk of breast cancer increases. OCP use increases the risk of breast cancer. If you have a family history, you have to check for mutations called BRCA1 and 2 in the blood. So this is all important in the history. So the symptoms of breast cancer we will evaluate. If you We will evaluate if the symptoms have, if the disease has spread to other organs. No seizure, no headache, no double vision, no dry cough, no breathing difficulty, no pain in the right side of the chest, no jaundice, no bone pains. That means most likely this patient has no weight loss, no spread. It is all local disease. Number one. Number two, you will ask for family history to check for BRCA. You will ask for OCPs and drug use. You will ask for prior hysterectomy or ovarian removal history surgically. Okay, because if you remove the ovaries, the risk of the hormones are going to be less, risk of breast cancer decreases. Nulliparity, whether you have never had kids, those things. So, and then you will physically examine the patient. Then it comes to test. The first test you are going to do to establish your diagnosis is a mammogram. Mammogram is an X-ray. Younger people, we do an ultrasound of the breast. That will tell me whether there is a lesion. After that, to establish my diagnosis, I will do a core needle biopsy, a needle test from that. If this is a lump, you will do a needle test. You will send that tumor for estrogen receptor ER, progesterone receptor PR, HER2 receptor Ki67, and sometimes a test called PDL1. So I will confirm the diagnosis with a mammogram and then with a biopsy and send it for ER, PR, HER2, Ki67 testing. Next question is, if cancer is confirmed, I will stage my disease. I will stage the disease with either an X-ray of the chest or ultrasound of the abdomen, or sometimes with a CT scan or a PET CT scan or a bone scan, depending on the symptoms. That is to see if the disease has spread anywhere. Finally, I will do tests to support my diagnosis or for the general health like complete blood picture, kidney, liver function test. Lastly, I may do a BRCA 1 and 2 for patients who have a family history or for men who have breast cancer. 1% breast cancers occur in men, or those who have ovarian cancer, or if a person has breast cancer on both the sides, you will do a BRCA, or somebody who has a triple negative breast cancer or a young lady with breast cancer. In these patients, I will do a BRCA. So mammogram biopsy, then scan, PET CT, CT, or whatever you want to do. Blood test, basic blood tests. A heart, we do a small test called 2D echo to check the heart function because we give some chemo medicines which can affect the heart. And finally, BRCA 1 and 2. This is your complete diagnostic workup for breast cancer.
So, after the diagnosis is done, how do you categorize the patient, or is there any specific classification that you follow for categorizing the breast cancer patients?
So there are two things. One, you should say what stage I am and based on my hormone status. So whether my disease is local, it's only in the breast, locally advanced, whether it has gone to the lymph nodes, or metastatic, it has spread. So localized, locally advanced, or metastatic. That is one. The other way to look at it is whether I'm hormone positive, HER2 negative, ERPR positive, HER2 negative. That's a good disease that is hormone responsive. The other end is triple negative, all negative. That's an aggressive disease. Chance of coming back is very high. Chemotherapy is the treatment with immunotherapy. The next one is HER2 positive. HER2 is another protein. If you're HER2 positive, you are given targeted therapy with targeted drugs like monoclonal antibodies, trastuzumab, we call that, or pertuzumab. So you are either hormone positive, HER2 negative, or you are HER2 positive, or triple negative, localized, locally advanced, or metastatic.
What would be the treatment approach for the patients who are HER2 positive?
HER2 positive means there is a HER2 signal. You have to block that signal. Keep it very simple. There are drugs which block that signal. They act on the receptor and they block the signal, because of which the cell dies. The drugs are called HER2 drugs, which are called trastuzumab and pertuzumab. So you will first start with these drugs. In the stage 4 setting, if trastuzumab or pertuzumab fails, you have other drugs like TDM1, TDXD. They are called antibody drug conjugates. We have already discussed that earlier. So HER2 breast cancer is a specific type of breast cancer. All patients with HER2 breast cancer should receive HER2 therapy. And only if the tumor is very small, like zero point 0.2 mm, zero point 0.2 centimeters, you will not give. So keep it very simple. HER2 positive breast cancer means there is a HER2 protein, HER2 signal. You have to block it. Give some medicines which are called trastuzumab or pertuzumab. You combine it with chemo, and then you stop the chemo and continue this drug. In those patients who are stage 1, 2, or 3, you give this drug for 1 year. In stage 4, you keep continuing this drug till the patient gets till the patient loses the response. If the patient doesn't get response or loses response, you change the drug from trastuzumab, pertuzumab to the newer HER2 drugs called TDM1 and TDXD. So if you give this drug, the chance of recurrence and death comes down by 50 to 60%. So today, all patients who have HER2 should receive HER2 directed therapy. And today in India, HER2 therapy has become so economical that most patients can probably afford it.
What can you tell us about the hormonal therapy for breast cancer patients?
So I told you hormonal positive means it's a good disease. They'll be given hormonal therapy. So in the stage 1 to stage 3, they are given hormone tablets, which they will take once a day. If you are premenopausal, you are given a tablet by name tamoxifen. If you are postmenopausal, we give you a tablet called anastrozole. So they basically reduce the hormone levels so that signaling comes down. So these drugs are given for a period of 7 to 10 years, daily one pill. Very, very inexpensive. The maximum side effect is some hot flushes and some sweats, some bone pains with anastrozole. So that's why we have to check the bone health, how strong your bones are when you're taking anastrozole, and we supplement them with calcium tablets. Again, in the stage 1 to stage 3, you give it for 7 to 10 years. In advanced stage, you keep continuing the drug till the patient has a response. If there is no response, you change from this drug to another hormonal drug, which is called fulvestrant. And in hormone positive HER2 negative stage 4, and even in stage 2 and stage 3, today we use a new set of drugs called CDK4 inhibitors. So earlier, in stage 4 hormone positive breast cancer, we had certain medicines, lamoxifen, anastrozole. If you progress, we were on fulvestrant. Then we discovered a drug by name CDK4 inhibitor. In this hormone positive HER2 negative, if you add this drug, the patient's survival has remarkably improved. Today, the survival in stage 4 hormone positive HER2 negative is more than 5 years. And the CDK4 drug is also a tablet. It is given generally for 21 days. There are three medicines: palbociclib, ribociclib, abemaciclib. Their side effects are generally fall in WBC count, some weakness, sometimes some liver function abnormalities, some ECG abnormalities, etc. They are very, very safe. Now, apart from stage 4, we are using these drugs in stage 2 and stage 3 also for a period of 2 years or 3 years. So, to put it very simple, hormone positive HER2 negative means very good disease. You will give hormonal therapy. In the 1, 2, and 3 stages, you give it for 7 to 10 years. In stage 4, you keep giving it till your patient is developing a response. Premenopausal, there is a drug tamoxifen, postmenopausal anastrozole. And CDK4 inhibitors have been used initially in stage 4. Now we use it in earlier stage.
So, what can you tell us about the triple negative disease? What about the treatment plan for it?
That is an aggressive disease, high chance of relapse. They need chemotherapy. And in early stages, we also add immunotherapy. In advanced stages, also in a set of patients, we add immunotherapy. If it is in an advanced stage, chemos are given, but the disease eventually comes back, and another set of chemos has to be given, or ADCs are given, like what we discussed. But generally, it's a very bad disease if it recurs.
Sir, what can you tell us about the prognosis for all of these classes of the breast cancer patient, like who are hormone positive, HER2 positive versus the TNBC
First of
disease?
all, talk about prognosis based on stage. Stage 1, excellent prognosis. Survival is more than 95, 98%. Stage 2 is more than 90%. Stage 3 is more than 60, 70%. Okay. Now, stage 4, if you're hormone positive, HER2 negative, I told you, survival is beyond 5 years now. If you're HER2 positive, patients can easily live for 3 to 4 years or 2 to 5 years also. Triple negative, yes, it's a bad subset, but patients in stage 4 still live for 1 to 2 years. So in first and second and third stage, we are talking about cure and cure and cure, high rates of cure. In that, if you're hormone positive, HER2 negative, superb. So earliest stage 1, hormone positive, HER2 negative means best patient. Nothing to worry. Stage 4, hormone positive, HER2 negative also will do well. So overall, it's breast cancer. You need not be afraid today. There are options, multiple options. Patients do well. Quality of life is excellent. Nothing to worry.
So, how does survivor care ship look for these patients? And like, what about the long-term recovery?
So once you stop the chemotherapy, they definitely recover within 1 month to 3 months. Hair loss comes, hair growth starts, taste comes back, appetite improves, energy levels, stamina is back. They have to come every 3 months for a follow up. If they cross 2 years, we say come every 6 months. If you're 5 years and beyond, you're cured, but still come once a year. The test during the follow up is a yearly mammogram. We will do CT scans or PET scans only if we suspect you are having a recurrence. Otherwise, it is regularly not required. In stage 4, you will keep getting your drug every 4 to 6 months a scan. If the scan is good and you are good, the drug is continued. Okay. So, one more thing which we should wonder is there are two things. Sometimes anthracycline we use as a chemotherapy in breast cancer. Very late, sometimes in patients, it can cause heart failure. So 3 4 years after chemo, suppose a patient comes with breathing difficulty. If you do an echo, if the heart is not functioning properly, your old anthracycline has destroyed the heart. Second, very late leukemias can occur in very less 1 to 2% patients. Blood cancers can occur after many years in very less amount of less number of people. So we should worry about that. Psychologically, once the time passes, patients get more confident when they have not had a recurrence.
So, what can you tell us about the screening guidelines for breast cancer patients?
Sorry, you
So,
are
we
asking
got,
screening
so,
guidelines.
yes, sir, screening guidelines for general population to prevent
Above
breast
40
cancer.
or 45, do a mammogram once every 2 years or once a year. Do regular breast exam. If you're above 40 or 45, get a mammogram once every year or once every 2 years. Above 75, it is not mandatory.
So,
And do a BRCA test if you're having a first degree relative who is positive. Suppose your mother has breast cancer, you get a BRCA in the blood.
okay. So, like, even without a family history, should women still be concerned about being at risk for breast cancer?
Definitely. There's no relation. There's a relation is there. I'm not saying so. Just because you don't have a family history doesn't mean you will not get breast cancer.
So, what can you tell us about the lifestyle changes for these cancer patients?
So during chemo, they will go through a lot. Okay, they have hair loss, loss of taste, loss of appetite, nausea, vomiting. They can't bear the smell of anything or the food and all that. So we ask them to take small, frequent meals a day, drink lots of liquids, green vegetables, balanced diet, fruits, fruit juices, little amount of exercise. After chemo, come back to your normal self and mentally be fine. Do some yoga, listening to music, gardening, emotional well-being. As we told, what is health? Health is not merely an absence of disease. Health is a complete physical, mental, social, emotional, and spiritual well-being. So even for a cancer patient, it's not just physically she has become okay now, the hair has grown and all that. Physical, mental, how she is, she's back in her good mental shape, spiritual, emotional with her family and all of them, social well-being.
So, what can you tell us about the second opinion campaign that you are running?
So we've been putting that upon Cancer Reach. We have a second opinion campaign. People, wherever they are, can reach out to us for an opinion, which is free. We would try to reach out to them as early as possible. This is just to give them a guideline or a guidance on how to go forward. Without seeing a patient, we cannot give a recommendation, but it is just to give them a guidance before they meet their oncologist.
Thank you for this wonderful session on the awareness for this October Breast Cancer Awareness Month, and we hope to see you again with an enriching topic again next Friday. Thank you, sir.
Thank you so much. Thanks, Kitty.
Sir, 1 minute, sir. Sir,
Yeah.
so we'll end this meeting here.
Mm-hmm.
So next Friday, I may not be available. We are
Okay.
having the half yearly meeting, sir. So I'll catch you again the Friday after that.
Thank you. Enjoy yourself.
Thank you,
Take
sir.
care. Thanks
Thank
so
you, sir.
much.
Bye, sir.